Anybody has an appointment in 2015 to write your name down in a sheet, and I'll make it happen a lot sooner. Yeah, like Oprah. Everybody gets a sooner appointment. Now, so what can we do here? Address it. Based on all the research that we've done, we have come to the conclusion that there's always 5 systems involved in any kind of pain. The CRPS, I like to think about CRPS as the epitome of the pain problem that has all of these systems involved to its maximum expression or capacity. There's the pain system, the one that tells you that there's pain. Then you have the affectual part of the pain system, the one that assigns a feeling to the pain. And these happen automatically. It's not up to the patient. It's either anger, depression, any kind of feeling gets involved automatically. This is the spinothalamic tract, the reticulospinal tract, which synapses into the limbic system. It's automatic. It's not up to the patient. Then after you have the autonomic nervous system, you have the motor system, and very much so, the immune system. Yes, a lot. So based on that, we try to diagnose our patients. First, we try to determine if there is central sensitization and what is maintaining it or contributing to it. Because a lot of our patients, just having CRPS does not prevent you from having a pinched nerve, facet arthropathy, any kind of extra pain problem that anybody else can develop. So we try to break down all the pains and aches and try to find the reason for them. So what we do nowadays is we determine, you have central sensitization. So that means that your central nervous system is at a different level than the regular patient. Yes?
So, does this include all other pains like back pain?
Every one of them pains. So I go over every pain that a patient has when they come to me, and I try to determine which is somatic, which is neuropathic, and where is it coming from. What?
Including our kids.
Including, yes, any kind of extra pain, your husbands, your kids, your job, anything. I address everything.
A pain in the butt.
A pain in the butt.
That's a big pain, yeah.
So, because what happens is central sensitization has to be maintained, or something has to be contributing to it. So once you're there, if you develop a facet arthropathy, that'll keep on working on that, and no matter how much ketamine we give you, lidocaine we give you, it may bring it down for a little bit, but the facet pain is going to crank it back up. So the way I explain it is like a volume. The pain volume on patients, the patients that I get to see, has been increased to a 10. So whatever hurts me, a 1 or a 2, a pain, my patients, they're going to feel it at a 10. Now what is keeping that volume at a 10? The changes from CRPS itself, the central sensitization, the ongoing glutamate, whatever Dr. Alexander just went over in detail. That is that. We address that by ketamine, but there has to be constant input of pain to keep it going. C-fibers activation. So, you may have broken a leg and developed CRPS from that, but if now you also developed facet arthropathy, or a radiculopathy, or a small fiber painful neuropathy, all of that is going to contribute to maintaining the volume at 10. So we give you ketamine, or you get ketamine at some other place, Washington, D.C., and it only helps for a little bit or doesn't really help, because there may be something extra on top of your CRPS that is contributing or maintaining this central sensitization process. So we need to address that as well. And then based on these findings, clinical findings, we determine what's the best treatment plan. Combination of a lot. So then, there's only so many things that we can do for pain. A lot of them, but only there's a limited number. So we like to think about 5 different treatment approaches. Medications. These include PO, oral medications, patches, whatever medication, whatever way we give it, IV patches, PO, intrathecal, this is included here. Then pain procedures, and this is what we do with epidural shock, catheter placement, brachial plexus, continuous infusion, epidural catheters, blocks, set blocks, rhizotomies, whatever we can do, or whatever I can do that involves a needle or anything other than medications, it comes in here. I included plasmapheresis here because I don't know, I don't think it's a medication, but it's not quite a procedure, but so I put it there, just put it somewhere. Then some patients require surgery, definitely. If there's a really bad pinched nerve, instability of the cervical spine, lumbar spine, and you require surgery, and we have to address it as well. I included here the implantation of permanent devices. Usually, me, it's only intrathecal pumps for delivery of baclofen or baclofen with clonidine and bupivacaine, never an opioid, because of what our research has shown. I don't do spinal cord stimulators because I have the time. It works, they work, but the majority of the patients that I get to see have been through that already, and when they get to see me, they say the same thing. It worked at the beginning, but essentially stops working after a few years, or after quite some time. So I don't do it here. Then physical therapy and rehabilitation, that works as well. And we have specialized physical therapists, and I like aqua therapy the best because I hear it always works, sounds like it always works. It doesn't hurt patients, and it's kind of the opposite of when the weather gets damp or when it's going to rain. Every one of you hurt more, right? Because of the atmospheric pressure changes, goes down. So getting into a pool increases the pressure. It's like a hug for your nerves. There are baroreceptors, atmospheric receptors in nerves. They've never been found on humans, but they have been found in mammals, cats, I think, and monkeys, never in a human being. But they certainly exist because patients do get worse when the weather changes, the atmospheric pressure drops, and every patient who gets into a pool feels the pain is better. So I like aquatherapy the best. And then pain psychology. And this does not mean that patients are crazy. What it means is just an extra therapeutic approach. Cognitive behavioral therapy, coping mechanisms, relaxation techniques, biofeedback. Group therapy is also very helpful, useful, like blogs. But it's better to do it face to face because you can share your stories. And we're trying to set that up as well in the clinic, but we haven't. We need money. Yeah. That's the thing. And so, let's see. Any questions? Because I think it'll be best if you ask me questions.
Enrique, did you want to talk about peripheral neuropathies and IVIG and
yes.
plasmapheresis?
So, what kind of patients do we treat? All kinds of patients. All. I see patients from any age, from any kind of pain, for whatever length of time, whatever therapy has been done for them. I get to see them all. That's why some of you have an appointment to 2016. Yeah, that's the problem. And regardless of comorbidities, prognosis, whatever it is that they have, I treat. And like I said, the majority of our patients have seen multiple doctors, multiple therapies have been tried, and multiple surgical procedures. Many, if not all, I think, have features of central sensitization. Otherwise, it wouldn't be a chronic pain. It would have stopped before, and way back. And possibly, the majority also have full-blown CRPS, meaning that they meet the criteria for CRPS. But some of you may not meet that criteria for CRPS, but that doesn't mean that you don't have central sensitization, and that does not mean that ketamine cannot help you. So not having CRPS is not an exclusion for being treated with ketamine. Having central sensitization is what can be helped by ketamine and what we do. Now, I guess all of you have heard of Mr. Schwartzman. So, I inherited all of his lovely patients, and I love them all. But some of them have come new to me, saying that, you know, at the beginning, it was kind of helping, but over the years, my pain went on to be felt on all of my extremities, 4 extremities. And it is burning rather than any other kind. And it is more in the hands and the feet rather than anywhere else. And then I developed really bad orthostasis. I get up and I pass out. Really bad gastroparesis, even though I'm not on any opiates. My eyes burn, they're dry. I have this really weird rash. And nothing seems to help now. Nothing. So then I started thinking, and then insurance companies, yay. They don't know it, but they help me out a lot. By blocking or by denying treatment for these patients, they force me to look into what else could I do for these guys. So then some of these patients came up to me saying, ketamine is now denied and I don't have the money. Please help. So I started examining them carefully, and I found this pattern of sensory loss in a glove and stocking distribution. Glove meaning hands, and stocking meaning feet more, and shield meaning more in the center of the chest rather than the shoulder. So then I thought, oh, this looks like a small fiber neuropathy. So I started taking about a year ago about skin biopsies to diagnose a small fiber. And I started to notice that patients who started out as CRPs, an injury, never before that had any burning, numbness anywhere, after a few years developed this pattern, who had a positive skin biopsy for small fiber neuropathy. I first treated them with IVIG, kind of helped a little bit, not too much, not that impressive. Then I thought, all right, lidocaine, let's try lidocaine. It kind of helped probably a little bit more than ketamine. So then there was this one patient who was desperate for any kind of treatment. So I analyzed her. She had an elevated set rate. She had a very unusual cytokine profile. It seems to be really inflammatory or immune-mediated. Limited set rate. Positive ANA, but nothing really specific. All inflammatory markers were positive, but nothing specific. No lupus, no sarcoidosis, no rheumatoid arthritis. IVIG kind of helped. Lidocaine helped a little more, and she was desperate. So we tried on her plasmapheresis. And it turns out that it really helped her burning pain. So then I started to pay more attention to those patients. And then I started to pay attention in the infusion suite to what happened to patients when immediately after they got their ketamine. Some of them started telling me, when I get it, I burn more for a week. But then I get a little better. Or some of them tell me, I tried it once, and it made me burn, and I don't want to try it anymore. So then I did the same thing. Okay, so tell me where you burn the most. Oh, I burn all over. All right. Is it more on the hands and the feet? Yes. Then I examined. Took a biopsy. Turns out that these patients, 80% of them, now it rose because I just received a little bit more. So 80% of them have a positive skin biopsy. And some of them have tried ketamine, but only 2 of them worked. The rest, it either did not work or made them worse, burning, or nausea, or migraine, worsened. But the ones that I've tried, plasmapheresis, it seems that on all of them, plasmapheresis made the burning better. At least the burning better. Right? And some of the features of pain. So, We don't know why, we don't know how, we don't know if it was there before the pain, but it was not obvious. We don't know if it was the consequence of chronic pain in the form of CRPS if you want. But they do develop the small fiber neuropathy that does not follow the typical course of any other neuropathy, small fiber neuropathy, like a diabetic or like, I don't know, an HIV patient. It doesn't follow that course, but they certainly meet that criteria, and they certainly have a positive biopsy. So we're treating them with plasmapheresis, IVIG, and whatever combination of any other procedure that they need. If they have a set arthropathy, radiculopathy, whatever else they need, we do it. Plus medication. Some of them, if I feel that the central sensitization is very prominent clinically, meaning that they have a lot of spread, they have a lot of oxidative discharge, and they have a lot of hyperpathia, I take those three as more of a central sensitization. Allodynia and all the rest of the physical exam may be central sensitization, but may also be peripheral, but not these three. If they have a lot of that, then I start them also on low-dose naltrexone, which Dr. Chopra is going to talk about that. And they do well as well with that. So what I want to really let you know is that we treat all patients, all pains. Every one of your pain will be treated depending on its etiology. Plus, if you do have central sensitization, we address that with ketamine, which is the best. Unless you have a very inflammatory profile, clinically and by blood work, then we try lidocaine plus plasmapheresis plus whatever other procedure, and obviously all kinds of medication except opium. Yeah. Does anybody have all right.
What is a plasmapheresis?
Plasmapheresis is a process in which your blood is filtered, all your plasma is taken out. Antibodies and inflammatory cytokines, chemokines, and other proteins, and all your red blood cells, white blood cells, and platelets are put back into you, and they replace that plasma with albumin and IV fluids. So it's just taking out all the inflammatory proteins, along with other proteins, and just bringing your blood inflammatory free, sort of speak.
Does that work better than the ketamine, or is it
Only in these patients who burn all over, who have this pattern of what I've seen, pattern of burning more in the hands and the feet, and who have a positive skin biopsy.
Is that after the ketamine? Burning?
No, you can have that even before. And I've tried, the first patients I saw were inherited patients from Dr. Schwarzman. But if I see patients now that they have this pattern all over, if they're going to pay for the ketamine, because this is where insurance companies come into play. Right, because when I get the biopsy positive, I change the diagnosis, and it doesn't matter, because you do have central sensitization. But it matters for insurance companies because they're not quite as bright. I just say, well, now my patient has a chronic inflammatory neuropathy, and then they scramble, they frazzle, they panic, and then they say, okay, yeah. So everything gets approved. Yeah, that's how insurance companies help. Right. So, that's what I do nowadays. If there's an insurance that's going to pay for the ketamine, then I still try it first. Because certainly the central sensitization may be addressed with it. But if I do find it on top, if the ketamine helped and I found small fiber neuropathy, I still give him plasmapheresis.
And how dangerous is the plasmapheresis?
It's not dangerous at all. The worst part of it is putting the catheter in. If you don't have good veins, they need to put a port. It's called a permacath. It's the brand. But that is the worst part of it. Otherwise, the rest of it is very simple.
And how long does that take? Was it a day?
Yeah, now, because we're the only ones who've done it, there's no guidelines.